Hello from Thessaloniki and from St. Luke's Hospital. First of all, I would like to thank Kostas Sparias for this very kind invitation, and Dr. Patakos as well. I'm terribly sorry that I'm not there. Actually, I had my tickets ready, but something went quite wrong with, I had a serious family issue, so I had to stay here. Anyway, what I'm going to present this as a team from St. Luke's Hospital. We were asked to create a video from our cath lab, and this is what we're going to show to you. And we've chosen a quite interesting case. I think it raises a few various issues regarding the combination of severe aortic stenosis and severe coronary artery disease, what to do first, and how to some tricks how to access the coronaries after you implant the valve. So we'll go ahead and we'll watch the video from our cath lab, and then in the end we can discuss.
Another talk or what? Oh, okay.
Sorry?
Are you okay? Is it all right? Are you all set? Είσαι εντάξει με την παρουσίαση?
Ναι, δεν τη βλέπετε?
Τη βλέπουμε, ναι. Απλώς επειδή φαίνεται από το κομπιούτερ. Εντάξει, είμαστε ok. Αν είσαι ok, είμαστε ok εδώ, ναι. Ναι. Τώρα καλύτερα. Τώρα τη βλέπουμε. Προηγουμένως δεν τη βλέπαμε. Έγινε.
Τώρα τη βλέπετε?
Όχι, προηγουμένως, το προηγούμενο.
Οκ.
Ωραία, προχώρησε. Εντάξει, πάμε καλά. Τη βλέπουμε. Εντάξει.
Ωραία, ευχαριστούμε.
Λες και τι βλέπουμε, ώστε να παρακολουθούμε.
Αυτό είναι το CT που βλέπουμε. Και εδώ είναι η αγγιογραφία του ασθενούς.
Ωραία, βλέπουμε τη βλάβη. We can see the RCA bifurcation lesion essentially, very big, very calcific lesion right before the bifurcation. Both branches very big.
Can you hear now the video?
No, we only hear you. We see the video,
sorry.
But we hear you.
Yeah, I'm sorry. I've had to go through because I don't know why there is voice from the video, but I don't know why you cannot hear it.
That's all right. You just help us yourself while we watch the video. That's fine.
Okay, I'm just explaining all the characteristics of the patient. Now, the idea is to perform the TAVI first, and then to perform the angioplasty through the struts of the valve, because the patient had an episode of loss of consciousness, and this is main issue is the aortic stenosis, but also the episode of consciousness, loss of consciousness, was preceded by chest pain. So we're going to do both of them, and I'm just presenting the team there. I'm sorry that you cannot hear the voice. I can hear the voice from here. I'm sorry you cannot hear the voice from the video, but I'm going to explain. I'm just introducing the team. So we cross the valve here. We perform the balloon. There is severe LVOT calcification, so we started the pre-dilatation with a smaller balloon. Okay. So this is the balloon dilatation. He went quite ischemic during the after the balloon dilatation, so we had to go. He was also hemodynamically unstable. His pressure was quite low, so we had to move quite quickly and put the Evolut Pro Plus. Our intention was this was 29 Evolut Pro Plus. Our intention was to do a proper commissural alignment in order to be able to access the vessel after that. So we position the valve in the cusp overlap view. And at this time, his blood pressure was quite low, so we had to be quite quick in implanting the valve. The patient became quite unstable hemodynamically. We tried, the first attempt was, the valve was quite low, so we had to reposition it. And we had to deploy it for the second time, and on pacing, we paced at 140. So this is the time of deployment. Okay. At this time, the blood pressure starts recovering. And it seems that in this bicusp overlap view, that the position at the non-coronary cusp is quite good. So we're doing an injection in order to assess the position at the non-coronary cusp. The position is quite good. So we're quite satisfied with the position as regards the non-coronary cusp. Then we went to the coplanar view, and we assessed the left coronary, the left sinus, sorry. So we were quite happy with the height, and we decided to fully deploy the valve. We just remove the pigtail, and we deploy the valve under pacing, 140 beats per minute, in order to stabilize the whole system. The other thing is that we release the valve very slowly in order to avoid any mislodgement. So the valve is deployed. The blood pressure at this time started recovering gradually. There is aortic regurgitation, as you can see, and we expected that because there is a lot of calcium, and there is a lot of calcium in the LVOT, but the position looks quite good. You can see that there is proper alignment of the valve. This is quite significant. So we're happy with the depth. We checked in the area of projection, and you can see that the valve is not fully deployed. We always have to check into projections. So we're going to post-dilate the valve. We did a post-dilatation. And this is a post-dilatation. We used the 22 balloon. We're a bit conservative because of the LVOT calcification. We didn't want to create any annular rupture, and but this worked, and actually the final injection shows only mild aortic regurgitation that was confirmed by an echocardiogram that we did at this time. So at this time we finished with the valve. The patient started recovering hemodynamically. And then together with me is Dr. Tsikaderis and Dr. Mezilis, with the team, the structural team at St. Luke's Hospital. And this is Dr. Mezilis took over now to go ahead with the angioplasty. You see how we access the ostium. Actually, to access the ostium of the right coronary artery, we have to go quite steep LAO. So steep LAO in order to have better access to the right coronary artery. And for the left coronary artery, it's LAO cranial view. We cross with the wire. You can see that there's a chunk of calcium, heavily calcified RCA. It's a superdominant RCA. So we started with a small balloon to see if this can create any space. And this is Dr. Mezilis. We selected a 7 French guide catheter because sometimes we may need to put a guide extension, 7 French, and do the rotablation through the guide extension. But we had a very good positioning of the guide cath, so we didn't need a guide extension. We tried to put a second wire in the PDA because the first wire was on the LV. There was a lot of difficulty in getting the second wire. We exchanged the wires, and then we managed to have both wires in PDA and PL. And then we tried the small balloon, the smallest balloon, just to create some space, but the balloon couldn't cross. Even the smallest of the balloon couldn't cross. You'll see that in a minute. At this very moment, the patient went into fast AF and he had severe ischemia, and also the blood pressure started dropping. And after crossing, as I said here, the patient went quite ischemic, even just crossing with a wire. So you can imagine if we hadn't do the TAVI first, that.
I don't know if you hear us, but we have a frozen image and no voice here. Any questions from the audience thus far? Any questions, anyone? Dr. Kilic, yes. Go ahead. Let's have some discussion time while he's reconnecting.
This case is a very good example to do coronary PCI before TAVI or after TAVI. Actually, the operator decision is good because I always afraid of this kind of right coronary arteries. Before TAVI, if any occlusion occurs, the patient had a severe aortic stenosis and patient can go to the cardiogenic shock. But there is a lot of discussion about this point, when to do PCI or TAVI, and we can discuss this, maybe. What is your opinion?
Yeah, well, everybody's going to give an opinion, and go ahead, come here also. We can all hear you because of the web. Let's see. We have first opinion. There are going to be many opinions. First opinion.
This is
also, Costa, you have an radiation.
That's what I'm going to say.
And also a contrast medium, an amount of contrast medium. Talk about also this.
For this kind of cases, one must have in mind that if you do two procedures in one sitting, you have much more contrast, and this kind of patients, 1 in 2 times have renal failure. Okay, so it's a good thing to have in mind that if you have corrected the aortic stenosis, then it's less probable that you will have a problem with the coronaries. But for this kind of lesion, I think it is a predictable lesion, and that could be treated before TAVI. I mean, you can see that there is a chunk of calcium, and if you plan a PCI beforehand, and okay, it's not a proximal lesion, which according to the recommendations now you should treat before TAVI, okay, but it's a distal lesion before the bifurcation of a superdominant right coronary artery, and it's simple to treat if you decide that you have the armamentarium needed. So you can go elegantly, use a few contrasts, decide from the beginning that you will use the rotablator, rotablate the lesion, put a stent, and several days later, 1 week later, come back and do the TAVI. I mean, I see the difficulties now, and maybe somebody can say that I am the wise man after the problem, but our strategy in our center is that this kind of situations, even ostial calcified RCAs, we treat them beforehand. And even if you decide to do it in the same procedure, you can do it, you can do the coronary first, you have the valve available, and you can treat without having the problem to access the coronaries after you have implanted the valve. And anyway, you will have a permanent temporary pacemaker. Anyway, you have a temporary pacemaker for the procedure. So
yeah,
that's my
well,
opinion.
temporary pacemaker, the least of the problem. You can always put one. Both the coronary and the valve needs it. We don't seem to have a connection yet. Dr. Asnauridi, what would you favor?
I would personally feel more comfortable to treat the coronary first. I appreciate that doing the...
Και κάνω share, έτσι.
Dr. Dardas, here? Do you hear?
I can hear you.
Okay.
I'm terribly sorry about that.
I don't have
Can you,
image.
okay, can you hear me?
Yes.
Yeah, but we have no image. We hear your voice. So we continue the... Oh, there you go. You back up. Go ahead.
Yeah. So sorry about that. I had a sudden problem with my internet, my connection. Now we're at the moment that we cannot... Can you hear me now? Can you see the
Yes,
picture?
yes.
Okay. Thank you very much. Oh, sorry. What happened? Sorry. This is the 1.5 rotablation. Okay, you can hear me now, okay?
Yeah, go
Dr.
ahead.
Dangas,
Yeah, go ahead, go ahead. Yeah, we see the rotablator, 1.5. What's
okay.
next?
Okay, this is 1.5. It crossed with a lot of difficulty, actually. It took some time to cross. It crossed in the end. So we did a policing, final policing with the rotablation. So you can see that it's quite straightforward to rotablate through the valve. There is no problem as we do our usual angioplasty. After that, we put the 1.5 modified the plug, but we put a 3.0 balloon, but the 3.0 balloon actually didn't.
The 3.0 balloon doesn't seem to make the turn.
Yeah, it was difficult to make the turn. Even the balloon, you see there's a lot of calcium there. So we went with a non-compliant balloon there, and we inflated at high atmospheres. And then we took a 3.0 balloon. It crossed relatively easy, but it didn't open the valve, the stenosis. So it was even at high atmospheres. You can see that the balloon is under deployed. So at this moment, we decided to go ahead with the IVL subwave and to do what we call rotatripsy. You can see at high atmospheres how the balloon is underexpanded.
Yes, we see that.
Okay. And then we put 22 atmospheres and the balloon doesn't open. And every time that we inflated the balloon, the patient went very ischemic. So again, this is to emphasize that the decision to perform the TAVI first in a patient with a gradient of 90 was the best decision. Okay. So this is a 3.5 IVL balloon. And we did perform about 7 or 8, if I remember well, inflations with a shock wave. And you can see that the balloon expanded well. Okay, you can see that we had a quite good result. And after that, we put a stent. This is after the shock wave. And we put a 3.5 stent. We post-dilated with a 4-0 balloon.
Well, it's already a great result, and I'm sure you optimized it a little bit more. I think this is great.
This is the final result, actually.
Yeah, amazing. The final result is great, and thank you for this great presentation. And you can see now, we can see very clearly that there was an intermediate lesion at the bend, exactly where there was problem delivering.
But we didn't do anything to this lesion. No. Actually, the patient had a very good outcome, and he was discharged a few days later. And this is a case actually that we wanted to emphasize when we have critical aortic stenosis and critical coronary artery disease, where you have to use rotablation or shock wave, and then possibly it's better first to fix the aortic valve and then go and fix the coronary. And there are some tips and tricks how to go through the struts of the evolute valve. We had to use an evolute here because of the LVOT heavy calcium. We had to use a balloon expander, self-expandable, not a balloon expandable valve. So these were the main, I'll stop the video. These were the main messages of our case. That when you have critical aortic stenosis, critical coronary artery disease, it's better first to consider fixing the aortic stenosis, and then it's not difficult to do the standing the PCI after the TAVI, following some rules how to approach the vessel. So thank you very much.
All right, great. In continuation, there's a great presentation, and we thank Dr. Dardas, a very complex case, to recanalize the evolute strut, the rotablator, a great case. There's also, as we said, it's possible to perform before, maybe less complex case. There's also possibility to perform high-risk cases before TAVI, facilitated by a balloon, a small balloon valvuloplasty, like an 18 or a 20 right before the coronary, in order to facilitate the coronary procedure, and then stage a TAVI. All these are possible. We saw a great example. I think we'll conclude the session.
I just had to say here that we thought to do a valvuloplasty, but after the 20 millimeter balloon, the patient went very, very ischemic and hemodynamically compromised. So we had to finish with the valve.
Yeah, good point, good point. Absolutely, good to be prepared for the valve. Excellent. I think we conclude this great session. Dr. Trikas, Dr. Asnauridis, and move on right away to the all-star next session. We invite the legends of structural heart disease, 2 surgeons from Texas, Dr. Mack and Dr. Reardon. They're going to Dr. Reardon, Michael Reardon, was the pioneers of